All right, welcome everyone. We'll be in Davis chapter 17 talking about priorities for the post-operative patient today. So go ahead and join me as we study this together. So really we're talking about when does post-operative care happen? It happens on a continuum for all the way from immediately following surgery until they're even home and doing home health. And the continuum really follows up until that first follow-up appointment, a week or two after their surgery. So we're talking about not just a day or two, but about a period of time. And hopefully during this time, the patient is improving each day. The postoperative care starts in the PACU, the post-anesthesia care unit. It's part of the surgery suite. They have pre-op, they have surgery, and then they have post-op or post-anesthesia care unit. And they're monitored closely right after the anesthesia because it's still in their system and it's wearing off. And so they're being monitored on a heart monitor, monitoring their heart rhythms. They're being monitored for their breathing, their vital signs, their oxygenation. And it's also a focus for controlling pain as the patients are beginning to wake up here and really making sure that their pain is well controlled. And as the patient wakes up in the post-anesthesia care unit, not only can they experience some pain that needs to be managed, but they can also experience some things like nausea and vomiting. And so the nurses in the post-op unit are really working to prevent any life-threatening complications and monitor those vital signs and provide comfort for things like pain, nausea, and vomiting. Now, there's three phases that we can think about for our post-anesthesia, post-surgery patients. The phase one is that most acute phase right after they're coming out of surgery. And this usually happens either in the PACU or in the ICU, depending on the patient, where the patient's vital signs are carefully monitored and they're slowly waking up from anesthesia. And the goal here is to really allow the patient to wake up, to control their pain, and also to make sure their vital signs are stabilized. And once those goals are met, then they're transferred to the phase two. And phase two can happen like in the med-surg unit back in their room, where the patient is really being prepared for discharge home, learning what they need to learn about wound care, making sure that their medications are under control, all the things that they need in order to be able to go home. And then that third phase, phase three, is really after they're discharged until their first follow-up surgery appointment. So where does post-op care happen? Well, it happens in a number of settings, and it really depends on the acuity of the patient. So it can happen in the inpatient post-anesthesia care unit or in the ICU, and that would be in the phase one of patient recovery from surgery. It can happen in an outpatient PACU ambulatory care center where patients go for same-day surgery. They come in the morning, they have their surgery, and they go home before the end of the day. And that's for obviously less sick patients. And then there's procedure areas that patients have to wake up from anesthesia. So things like cardiac catheterizations, patients undergoing colonoscopies, patients have to wake up from anesthesia in those kind of care areas as well. Now, as we're caring for the post-op patient, there's a number of different things to consider, but we want to recognize that all patients respond differently and each surgery is a little different. And so we really have to provide individualized care. But as we're doing that, these are some of the things we're talking about. So assessing and monitoring the patient's response to the surgery procedure itself, as well as to the anesthesia, providing timely interventions to resolve whatever problems the patient might have at that time, or any concerns or needs of the patient. And we can think about the physical needs and concerns, or the psychological, psychosocial, or emotional or spiritual needs as well. Of course, there's an evaluation of interventions. Anytime you do something for a patient, you need to evaluate whether it worked. And so that's going to be things like evaluating the interventions for things like nausea medications or opioid medications. Did they work? Were there any adverse effects that we weren't anticipating? And evaluating anything we're doing to provide care to this patient. Reassessing the patient's condition, and that includes focused assessments depending on the body area that was being worked on in surgery, as well as monitoring those vital signs, mental status, any nausea, vomiting, or pain. And then, of course, evaluation of achievement for discharge goals. So discharge planning happens at the point of admission. So we start thinking about how are we going to get this patient home the very moment that they're admitted to the hospital. And so we want to make sure we're starting to tick those boxes and reaching those goals to make it closer to that patient being able to go home. So as soon as the patient is rolled into the post-anesthesia care unit, the PACU, from the surgery suite, not all assessments are created equal, and there's certain assessments that are going to be most important for us to do as nurses. They'll be hooked up to a cardiac monitor, they'll be put on a pulse oximetry and a blood pressure monitor that's cycling every 5 minutes and giving repeat readings. And in addition to those vital signs, we're going to be looking at, do they have a patent airway? What's their respiratory stat? Are they breathing? What's their rate? Are they breathing deeply, shallow? How are their vitals? Are they starting to wake up? What's their level of consciousness, their neurologic function? How about their skin temperature and skin color? Are they in any pain? What's the condition of the dressings? Dressings after surgery should be dry and clean, and they should not be soaked through. Do you have any visible incisions that are open to air that we need to assess? Are the wound edges approximated, meaning close together? How about their IVs and any drains or tubes that they have? Are all of those drains and tubes working? Do they look good? Is there any sign of infection or irritation? And what's the hydration status of the patient, including, do we need any IV therapy for this patient? Now, there's a couple of diagnostic tests that can be done post-operatively, and those can be done to assess bleeding, assess for fluid loss or electrolyte imbalance, to check their renal function. Remember, these anesthesia medications that are given in surgery can have a significant impact on the patient's bodily functions in general. And how about their clotting status? Are they having any blood clots that we need to be worried about? A chest x-ray can help if we're worried about any problems with the intubation or the anesthesia. And an EKG or an electrocardiogram is always done preoperatively and can be done postoperatively as well if we're noticing any heart rhythm changes on the monitor. Now, patients coming out of surgery are going to experience pain, and there's a number of things that we're doing in the immediate post-op phase to help manage that pain. Analgesics, including opioid and non-opioid medications, opioids, controlled substances, non-opioids like NSAIDs, ibuprofen, Tylenol can really be helpful, and they're often used in conjunction together, with the goal being to get patients off these opioids as soon as possible. They've also found in studies that non-pharmacologic interventions really can decrease pain. And these can include things like music therapy, massage, prayer, and meditation. However, many post-op units do not provide these types of services. Another nice option for post-op patients are these PCA pumps, the patient-controlled analgesia, where it's set to allow a specific amount of the controlled substance over each hour, and the patient gets a button, and every time they feel like they need pain, they can press the button and another dose of the medicine will be provided through the PCA directly into their IV, and it times out and locks out every hour if the patient is getting too much. Now, one main complication in the PACU is managing nausea and vomiting. Now, nausea and vomiting is something we want to control in the post-op area because it can lead to some complications. These complications include increased length of stay, an inability to perform their own activities of daily living, even ER visits and readmission to the hospital later on, and the wound dehiscence, the risk that wounds will come apart because of this, the heaving that happens when you're vomiting. We can also see things like dehydration and electrolyte imbalances. So because of these complications, we want to be attuned to patients who are going to be at risk for complications and then make sure that we're treating it appropriately. So those risk factors for patients who are going to have more nausea and vomiting post-op are going to be including young, non-smoking females, interesting, a history of motion sickness, or if they've been under general anesthesia. So all of our real surgical patients are all under general anesthesia during surgery, and so this is something we're going to want to really tune into. Now, the treatment is oftentimes minimizing opioids after surgery can help reduce that nausea and vomiting. And then providing pharmacologic interventions, like we've talked about, ondansetron, which is Zofran, is an awesome IV medication that can be provided that really does a nice job at reducing nausea. Other potential complications after surgery include respiratory depression, breathing less than 12 times a minute, and that's due to all the anesthesia medicine that's in their body. Patients experiencing significant pain, or even bleeding at the incision site can be causes for alarm and things we want to watch for as we predict potential complications as post-op nurses. And your Davis has a really nice table on page 330 to 331 talking about different complications of post-op patients, and I would encourage you to take a look there. So let's talk about the nursing management of our postoperative patients. In terms of assessment, we're going to be looking at their neurofunction, looking at their level of consciousness, and if they're experiencing any restlessness, agitation, or confusion. And it could mean they're coming off the anesthesia and having a hard time with that, or it could mean that they're hypoxic. So we want to really tune into their oxygen status and make sure that they're getting the oxygen and ventilation that they need. We're going to want to watch for their vital signs. Patients post-op in the phase 1 can have quick changes in their vital signs as they're coming off this anesthesia. So we want to watch their vital signs every 5 minutes in that first phase 1, looking for their ranges of blood pressure, heart rate, oxygen saturation, respiratory rate, and temperature, as any changes in those could indicate a postoperative complication. We're going to want to check those peripheral pulses, those distal pulses, knowing that we're getting good circulation to the tips of our toes and the tips of our fingers, wanting to see that the patients have good skin temperature and skin color that shows good perfusion, total body perfusion. We're going to want to watch that urine output. And a lot of times patients after surgery will have a Foley catheter in, sometimes not. But of course, that rule of thumb is 1 ml per kilo per hour is a minimum amount of urine output. We want to make sure that their kidneys are working and they're producing urine. We want to assess the patient's pain, and we might need to use those nonverbal pain cues in the immediate post-op phase to make sure that we're understanding if the patient's in pain, looking for things like changes in vital signs, tachycardia, blood pressure being increased, respiratory rate being increased, or grimacing, or other things like moaning, or the patient actually reporting that they're in pain. And of course, we want to look at their skin and perform a skin assessment, looking at any drainage or excessive blood on the wound dressings that could indicate that there was, a significant amount of bleeding or inadequate wound closure, which we would want to call the surgeon about. So let's talk about what actions a PACU nurse takes in their day-to-day work. The PACU nurse is going to connect the patient just as soon as they get out of the surgery suite and into the PACU, connect them to the heart rate monitor, start that an assessment on the patient immediately, documenting their vital signs, typically every 5 minutes initially, getting a handoff from the OR nurse. How did it go? What did they have done? What are their most current set of vitals? What kind of history do they have? What medications have they been on? What medicine did they get in surgery? We're going to have continuous monitoring of their blood pressure, their heart rate, and respirations, their full vital signs, and then giving any medications as ordered. Like I said, typical immediate post-op medications are going to be including things for pain and nausea or vomiting. And then once we get the patient done with phase 1, we are able to then hand them off to the inpatient unit. And so then the post-op PACU nurse would be calling an SBAR handoff report to the inpatient nurse who's going to be receiving that patient on the medical surgical unit. And then we're going to talk about teaching and involving the family. If you've ever been the family member waiting for a patient to get out of surgery, it can be really nerve-wracking. My son broke his arm earlier this year and had to have surgery, put 3 pins into his arm. And my husband and I were a nervous wreck, during the time he was in surgery. And then the surgeon came to tell us that it went well, but we weren't able to go back to the PACU just yet to see him. And it was really hard to be away from him and to worry about his comfort and his safety. So keeping the families involved is really a key role for you as the PACU nurse. And then keep in mind that patients who've had general anesthesia or even moderate sedation oftentimes have kind of a short-term memory loss and will not remember many things from that day. So you don't want, if the patient is going directly home, say if you're in an outpatient PACU or you're doing same-day surgeries where the patient comes in the morning and they go home at that night, you want to provide any discharge teaching to the family member who's going to be assisting this patient, because the patient themselves will not remember likely anything that you told them about discharge. Okay, so that's going to wrap it up for part 1 of our post-op care video. Come back for part 2, and we're going to talk about what looks like to care for a post-op patient in phase 2 on the inpatient medical surgical unit. I'll see you back here for part 2.